Well, hello everyone and welcome back. You can see that our brilliant experts have joined us again for our Q&A panel. I'm pleased to say that we have Perry, we have Juan Pablo, we have Jerry, Robert, Costas and Helen. As you can imagine, we've had hundreds of questions submitted and we'll try and get through as many as we can. We're not going to get through them all though, and so do please give us a call on the helpline on Monday. And speak to one of our nurses if your specific question hasn't been answered. So I'm going to crack on, because we don't have a huge amount of time. And let's look at the first question that's come through. It says, what role can vitamins play in helping manage cardiomyopathy? And what about diet and alcohol? Jerry, I'm going to go to you first, if that's all right. What's your views?
Yeah, of course. So I think nutrition is really important. I think the key is to have a healthy diet. I think most people with cardiomyopathies will do very well. And actually the healthy diet to try and prevent other cardiovascular problems, cancer, is potentially more important. So a balanced diet, a Mediterranean diet, probably has some cardiovascular benefits. I think if you have a good diet, there's probably no evidence that any particular vitamins are beneficial. So I would suggest just to focus on a healthy diet. And if you do that, I don't think you need any supplements at all. Alcohol's a good one. You have to drink less alcohol than your doctor used to be the old adage, and I'd sort of suggest people do follow that. But I think alcohol in moderation is probably safe. We're talking less than 14 units a week. We're talking 2 or 3 days without any alcohol. And I think following that is very sensible advice for the sort of wider benefits. So they'd be my thoughts, John.
Anyone else want to sort of jump in on that one?
I think I need to say, it's just because you have cardiomyopathy, it doesn't mean that you're not at risk of all the other stuff the general population gets. So as Jerry says, I think there's very little evidence that diet, nutrition and so on have a direct effect on cardiomyopathy, with a few maybe very unusual exceptions. But living a healthy lifestyle, reducing your risk of getting high blood pressure or coronary disease is just as important if you've got cardiomyopathy as for anybody else.
We're talking about healthy lifestyle. We have a question that comes up. It's probably come up in some of the breakout sessions, and I'm sure we get asked a lot, is does exercise, really about exercise, and I suppose, does exercise advice differ for the different types of cardiomyopathy, and if so, why? I thought, Costas, maybe you start off talking a little bit about ARVC, and we can maybe take it from there.
So I think it's, exercise is always a question that comes up, and obviously it's quite important. Apart from, our general recommendation in cardiomyopathies in general is that, people should avoid, high intensity and endurance sports when they express the phenotype, because we know there is potentially a risk of sudden death associated with that, or disease progression. But we should. Patients should definitely continue to exercise, and a healthy level of aerobic exercise and keeps up the cardiometabolic and positive effects. And this also has positive effects on heart failure, but also, not looking only at the cardiomyopathy, but on the cardiovascular system per se, but in the psychology of the patient. So generally, a healthy level of exercise is recommended in all patients with cardiomyopathy. Now, if we go specific, we have discussed it in the session. In some of the specific cardiomyopathies like ARVC, we know that endurance exercise and very, very high level in intensity sports, they can provoke the phenotype and potentially lead to a worse or more severe phenotype, provoke arrhythmias. And this is something that, it has to be individualized in most of those patients, depending on the genetic background. I think, even the current guidelines, it's very difficult to put a general recommendation for all cardiomyopathies, but it does appear that exercise is being seen more and more safe in quite a few patients with cardiomyopathy, and this is depicted also in the modern guidelines that actually allow for a higher level of exercise, and to obviously give all the benefits from the exercise without putting at risk the patients with cardiomyopathy.
Okay. Robert, can I ask, is that also true for Takotsubo? Is that a bit of an outlier? Do we know about exercise in Takotsubo?
Yeah, well, the ESC Congress recently, the new guidelines presented on exercise in cardiovascular conditions, and there wasn't really any specific mention of Takotsubo's as a distinct entity in there. So you kind of left to extrapolate from the guidelines regarding other conditions. And I guess at ECHO, it has to be individualized risk. If you're someone who is at a high risk in terms of maybe a previous exercise-induced tachyarrhythmia, or if there's any evidence that the cardiologist tells their patient that there's outflow tract obstruction, these are all things associated with higher risk, and therefore their sort of risk of exercising at a higher intensity would be significantly greater, I would suggest, than someone who appears to have made a reasonable recovery from Takotsubo, but I'm not aware of any specific exercise guidance.
And one, is that something? Is it true for young people as well? Or does it make any difference?
So it's a very good question, and actually one that we get asked a lot. And I agree with Kostas's comments that it's important to balance the potential risks from very competitive, very strenuous exercise, which probably lower than we have thought in the past, with all of the benefits of exercise, not just from a medical perspective, particularly in the context of sort of current obesity pandemics in the pediatric population, but also from a psychological point of view and a social point of view. So our advice always is to encourage children and teenagers to take part in physical activity, to do PE at school, to listen to their own bodies. So if they're doing something they don't feel quite right, they should be allowed to stop and take a rest and let somebody know. Avoiding very competitive and very strenuous activities, but I think a lot less restrictive than we perhaps have been in the past.
I think I'm going to move on to the other one. I mean, like I said, there's lots of information about cardiomyopathy and exercise on our website as well. Helen, this is probably one for you, if you don't mind. There's a question that's come in. It says, how far away are we from knowing all the genes that cause cardiomyopathy and testing for them?
So that's a very difficult question.
Sorry.
No, it's okay. I'm glad that someone asked it. I think it's the sort of question that makes me think we don't know what we don't know. There are many genetic diseases in which we've kind of been able to make a diagnosis in, for argument's sake, 20%, 50%. For some of those over the course of 5 or 10 years, that's dramatically turned around, and the percentage is much higher. But for others, we're still stuck. So there's a whole load of genetics that we just don't know and understand. And if I were a betting woman, I still wouldn't dare to place a bet on how long it's going to be.
What do others think? Anyone want to jump in on that one?
Yeah, we're chipping away. I mean, hands on. I mean, the genes that are out there are going to account for relatively small numbers, of their total pie. But if you look back over the past 3-4 years, I mean, we've had 1, 2, maybe 3 different genes, which are chipping away at that. I think what's very clear is that even when people are mutation negative, when you look at their families, it's very clear they have what we call dominant disease. So it's looking in the right place for the mutations. So they're gonna tick away. I think it's in my talk I always push it up to about 60%. I think that feels about right. Maybe even a smidgen more, and then the rest of it's going to be a mixture of multiple effects of genes which are relatively small, or some of the things that are lurking in the population, like amyloidosis and that sort of thing.
Okay. Thank you for that. There's a question came in here. It says, how hopeful should we be about the future? I assume it's I think it's specifically for people with cardiomyopathy. I think, why don't you start on that? Because from the young people's point of view, I mean, they're the ones who are going to see more of the future than anyone else. So why don't we go with that?
So I'm sort of naturally a very optimistic person, but actually I think we do have a lot of cause to be optimistic and hopeful about the future for cardiomyopathy, for sure. And the reason I say that is that it feels like we're moving into a completely new era in terms of how we are managing cardiomyopathies. So whereas for many years, really from as far as we've been managing cardiomyopathies for the last few decades, it's always been a question of treating symptoms, trying to identify and prevent complications, but very little else other than that. But over the last few years, what we've seen is a change towards new therapies that are really much more personalized and much more individualized. So mavacamten is the big drug now that was one of the big stories of the European Society of Cardiology, and it's a drug that is a completely new class of drug, that it targets the underlying pathophysiological mechanism of hypertrophic cardiomyopathy. So that in itself is a brand new avenue, but increasingly what we're seeing are gene therapy approaches that have been used in other conditions, Duchenne muscular dystrophy, hemophilia, things like that, that are now also coming into the field of cardiomyopathies. Even mavacamten in the animal studies, when given to mice who are mutation positive but don't have the phenotype of left ventricular hypertrophy, they seem to prevent the development of, or the drug rather seems to prevent the development of left ventricular wall thickening. So I think it's a very promising time, and I think within the pediatric cardiomyopathy population, I think we're really uniquely placed to develop these sorts of new therapies, because I think we have a population of children who potentially carry the gene change that is present in the family but haven't yet developed the features of the condition. So if we're able to target that particular bit of the life course of the disease, we may well be able to prevent the development of the condition in years to come. So I think there are lots of reasons to be hopeful.
Well, does anyone else want to jump in a bit on that? I mean, Jerry, if you had a crystal ball, is it things looking good? Are they things looking better or worse? Or
yeah, no, thanks, John. So I think a few things. I think even as they are now, I think things are really good. So I think if you look at people with cardiomyopathies, 90% of them will be doing really well 10 years later. So outcomes with all the sort of drugs and everything, defibrillators we've got at the moment, outcomes as we are right now, I think are really good. And I think a lot of people with cardiomyopathy go online and read about heart failure and get very worried, and that's just completely different to the outcomes with cardiomyopathies. So the outcome where we are now is really good, and I think the future is really exciting. I mean, the new treatments for HOCM look great. If you look at some of the sort of microRNA work on regenerating damaged heart muscle in dilated cardiomyopathy in the animal models, the stuff I've seen over the last year is just incredible. And if that comes into fruition, that will completely change the outlook for all the dilated cardiomyopathies. So I think we're in a really good place now, and there's so many new strands coming through. I think the future is really hopeful. So yeah, no, all very positive. Don't need a crystal ball.
Okay, that's great. I think one of the things that has come and become available recently, we have had quite a few questions about it today, is Entresto. Does anyone want to say a few words about how it's been used in cardiomyopathy, what this sort of what the outcomes have been, any side effects? I think anyone want to take that one on first? Very lucky you get to do that.
Shall I make a start then, Joel?
Yeah, go, Joe.
Yeah, so just to be clear, it's for people with dilated cardiomyopathy with an ejection fraction below 40%, who are still having symptoms despite maximal ACE and beta blocker. And in that group, it perhaps has twice the effect of ACE inhibitors if you look at the trial. So that's the setting. We use a lot of it, and actually we've had some patients just transformed on it. We've had some where it doesn't change very much, but I think in that specific group, it's a really useful drug. Yeah, you have to be a little bit careful with blood pressure, and some of them have a diuretic effect, and you have to reduce or stop the diuretics in a few of them. But it's a pretty safe drug. I haven't seen that. There's a few rare side effects, but most people, provided they have the blood pressure to start it, tolerate it well. And a lot of people get a real improvement in their symptoms. So yeah, I'm very pleased with what we've seen with it so far.
Yeah, I think it's, as you say, Jerry, I sense this year at ESC there's a sort of a tipping point for Entresto in that people are now talking about quadruple therapy as being standard in patients with dilated cardiomyopathy, heart failure, reduced ejection fraction with Entresto. Very clearly, they're actually in the place of ACE inhibition. Now, that is a little bit of hype, but that's the logical direction of travel for Entresto. There's some interest in hypertrophic cardiomyopathy, so Novartis is starting a trial in HCM. For me, another interesting thing about Entresto is the comparison, actually. So Entresto, I think, is clearly probably a bit better than ACE inhibitors, but when you look at some of the fine detail, for example, its effect on quality of life, it's not that impressive, but then it's not that impressive for ACE inhibitors and similar drugs. Whereas if you look at what's happening, for example, with mavacamten, or if you look at the treatment of amyloidosis, we're seeing big effects on quality of life. So there's always this sort of double thing you're going for. You're trying to make people live longer, but you also want them to live better. For me, that's very much the focus for some of the diseases like hypertrophic cardiomyopathy, where we can prevent premature mortality, but it's about the quality of life that you have for the next 10, 20 years, which is really important.
Let me go on to the next question. We've had a few questions relating to, I suppose, the language we use in cardiomyopathy and the terms that are. And I suppose the best defined is how important are those terms? There's people who've heard ARVC and arrhythmogenic cardiomyopathy. There's someone was told they had trabeculation. Is that the same as LVNC? And I think for me, Takotsubo, does it feel like an outlier because it's not called something a bit more medical and less sort of octopus related? So the language makes a difference, and it would be interesting to hear your thoughts. I mean, Robert, maybe start with Takotsubo, and what would happen if we called it something cardiomyopathy? Would people take it, think about it more?
I think there's a general rule in medicine that everything needs at least 3 names that can be used sort of interchangeably depending on the situation and the audience. And Takotsubo is a classic example of that, where it's, I think you have to, in some cases, you have to name all 3 names before someone recognises what you're talking about. I don't know. I think Takotsubo cardiomyopathy seems to be sticking now. I would suggest. I don't know. Defer to my more senior panel members, but I would say that that's probably the term that's going to be around for the longest. The others, certainly, I mentioned in my talk, apical ballooning, stress-induced, they are still used, but they're kind of descriptive. And I think personally, Takotsubo is quite an elegant name myself.
I think the media prefers to call it sort of heartbreak, which probably isn't that helpful.
Suitably emotive.
Yeah, and Costas, I mean, you had quite a few questions in your sessions about trabeculation and LVNC, and then ARVC or arrhythmogenic cardiomyopathy, and how do you sort of navigate that?
Yeah, that's. I think the amount of name also in all cardiomyopathies, it also represents our a little bit of history, because just getting to. I mean, if you see, the ARVC is the classic example. And when it was first described in 1977, people were talking about dysplasia. They were looking at something. The pathologists were looking at something that they couldn't really figure out what it is. So it was called dysplasia because people were thought that it may be just a dysplastic thing, so just a thing that a little bit out of the norm. And over the years, it just developed, to right ventricular dysplasia, then ventricular dysplasia, and right and left, and now it's arrhythmogenic cardiomyopathy. So it shows, our confusion, but also our understanding as well of how our understanding about the pathogenesis and the pathophysiology of the cardiomyopathies has developed all over the years. Now, in terms of trabeculation and LVNC, that's another classic example where, I think we have just induced a lot of confusion, both in the communication between ourselves, but also, obviously with the whole world. And I mean, trabeculations, Jerry may have mentioned that in his talk, but trabeculations is generally something that we find in specific normal situations, like pregnancy. We can find it in athletes. We can find a lot of those things that we describe, maybe just a normal variation, but also they may be part of some specific cardiomyopathy. So yeah, so it's sometimes it's very, very difficult to actually give the name. Or so the way I like to see these things, especially with TCM, left ventricular non-conduction, ARVC, sometimes is to see them as a long line of spectrum. Potentially also, if we include the hypertrophic cardiomyopathy, which tends to be a little bit out of the box there. But I like to see them in a long line of spectrum of cardiomyopathy, which there's a significant amount of overlap between these. And in the end of the day, the exact name may not be so significant rather than what we're actually doing with a specific phenotype that we see. And, in most of the cases, we actually end up doing the same things, which is assess the patient about symptoms, assess the patient about prognosis and risk, and also, assess the family. So I think, in my eyes, this is probably the most important thing. And it was shown as well with the different names.
Anyone else want to jump in on that one? Has anyone got any strong views? Looking at you, Perry, you look like you had strong views.
No, just it sparks all sorts of reflexes. I mean, I agree completely with what Costa said. I think it gave a really nice summary. There is a lot of historical baggage, and it represents evolution of knowledge. Unfortunately, I think it also represents a very simplistic approach amongst cardiologists, to be honest with you. Because we like to have a number, we like to have a box that we can put things into. And as Costa said, life is more complicated than that. And when we make a diagnosis, it's rarely on the basis of a single parameter. First of all, why is that person sitting there in front of me? Is it because they've got a family history and someone in their family has died suddenly? But they've got an abnormal ECG. What does the imaging look like? Is there a bit of scar? Do they have some other systemic signs? So it's actually not a huge list of things, but the diagnosis rests on more than just a trabeculum or more than just a single parameter. But unfortunately, I think medicine generally has become very reductionist, and we're measuring single things and treating single numbers. And I think that to me is a big mistake, because it misses the bigger, more complex but still understandable picture.
Thank you. I'm going to move on to the next question. We had quite a few questions, I suppose, regarding the process of getting treatment and how centres of excellence work and what sort of excellence looks like. I thought, Helen, if you don't mind, I'll come to you first, just to think a little bit about the role that sort of genetics and maybe sort of genetic testing might play in that. If you thought about what the ideal treatment would look like.
So excellence and centres of excellence, that's a really difficult question. I think that there are many who are trying to kind of even up the picture across the country. There are particular centres where there are people with vast amounts of experience. Perry, I'm looking at your picture at the bottom right of my screen, of different cardiomyopathies who've developed multidisciplinary models of care that attend to all of the patient's needs. That's not been possible in every single hospital across the UK, and I think those inequities are being felt quite sorely by some people. So I would say, all I can say is that in our own centre, we've not done badly. I work in the West Midlands, it's a big centre. We've managed to attract funding for inherited cardiac conditions nurses who can be accessible by the patients, but who know what's going on and can act as a sort of central focal point for for everybody really, and we've got enough genetics input, we've got enough resources to pay for testing, we've got some expertise to use those results. It is all evolving. As people realise that this work's going on, the demand goes up and our ability to meet it starts to sort of peak. And so I think really an ideal model of care is a multidisciplinary team with everybody chipping in to do what they can and to really address patients' psychological, family, and obviously the paramount their medical needs too.
Jerry, I know you're obviously doing a lot of work on the way care is sort of structured, certainly in the sort of southeast. Do you want to sort of add a little to that?
Yeah, so I think the world's changing. So the way the health service is being funded will change. We're going to be, rather than payment for every little bit of activity, it'll be block contracts, but they'll also be given to a sector rather than an individual hospital, I think. So, and there's lots of reports going to come out in the next sort of 2 or 3 weeks, I think, saying the health service needs to move towards networks rather than individual trusts or primary care trusts. So I think the world is changing, and I think that's a good thing. So if we base how we work along an integrated care system, which is, say, a population of sort of 3-4 million people, then you need a functioning network in that geographical area. So that's an overarching specialist centre. But you know, a specialist centre can only see 5% of the prevalent population. So that's got to link into all the district general hospitals, but and into primary care. But, you know, COVID has many bad things, but one of the good things it's done is enable work like the conference today. So actually functioning networks with the technology we brought forward in COVID is the only way we're going to do it really well. And the change in NHSE structure will allow us to do that at pace, I hope. So I think that is the way forward. The biggest challenge is getting into primary care. That remains the biggest challenge. But I think that's a very good way to work. And the virtual MDTs that certainly we had over COVID times were, you know, I think transformed how we look after patients. A lot of the time, patients don't need to travel up to sort of North London and places. They can just be managed close to home with virtual consultations with the patient or between the doctors. So I think this is all going to change I hope it'll change in the next few years.
So Jerry, you mentioned sort of COVID there. I mean, last time we did this was at our conference in London, and it was against the backdrop of Brexit. And there was lots of questions about medication. There haven't actually been many questions about COVID, actually. I think a lot of people sort of have had some of those answered already. But there have been some couple of questions submitted which I think are related, and tell me if I'm wrong. So someone has asked, if and when a COVID vaccine is produced, would it be safe for people with DCM? And it may be related to another question, which is, with DCM as a suspected cause being viral infection following an autoimmune activation, would an antiviral medication be used? So maybe it's a question about the connection between sort of viruses and cardiomyopathy, and I think maybe DCM and potentially sort of space Takotsubo might be part of that. And how does that work with a potential COVID vaccine? That's a 2-for-1 question. If anyone wants to start. So, Perry, do you want to give us some of this sort of the clinical space background in terms of viruses and how that can lead to DCM?
God, there was a lot in that question, John.
Yeah, sorry about that. let's do viruses and cardiomyopathy first.
I mean, vaccines, you have to be safe for everybody. So I think if it's safe for someone without cardiomyopathy, one would hope it would be safe for someone with cardiomyopathy, but obviously anybody with underlying condition, we have to be careful. I think it's why we want a vaccine as soon as we possibly can, but it shouldn't be rushed. It has to be safe. The viral question is an interesting one. I mean, that's a debate that's been going on for decades. And I'm looking at my colleague Costas, who's worked in the temple of virology and cardiomyopathy in Berlin. I think that, I think part of the problem, I mean, Jerry's given, I think, a very eloquent description of sort of the way in which systems are going to change. But I think we also need to change the way in which we train our skill sets, because there's some gaps. So as a cardiologist, I'm not trained in virology. I'm not trained in autoimmunity. I'm not actually trained in genetics. But here we are talking about a whole spectrum of disease, which requires at least some understanding of those things. And I think what we tend to do is we sort of look around, yes, Helen knows, where's my friendly geneticist? Well, there might be one around, but there aren't many of you. We look for a virologist or we look for an immunologist, and they're not there. So as well as developing systems, I think we also need to develop skill sets. And I think that's how we train the cardiologists of the future. This is not answering your question, but ARVC is important. Well, to do that properly, you need people who understand the cardiovascular pathophysiology as well as viral infection and can study that. And I don't think we have enough of those kind of people around. They're what cost us things.
Yeah, no, I fully agree with that. I mean, this debate has been, viruses, no viruses, genetics, no genetics. I think that the big wall was not really inside Germany, but it was probably between Germany, Italy, and the rest of the world in that particular point. But so I think, we need to understand a bit better what's, what is the cause. I think we now understand a few things more than potentially it's not just the virus or the genetics. That's probably both in some occasions, and the interaction between these two. And going back to whether the vaccine will affect in any way dilated cardiomyopathy. I think it's as you said, Barry, it has to be safe for everyone. I think it's going to be safe for. It's going through different phases of testing and safety, and it should be safe also for patients with cardiomyopathy and dilated cardiomyopathy. But, sometimes we do, and seeing, what the COVID, the whole pandemic and the effects of COVID, I think we come to realize that there's a lot of unknown there. And, the effects of COVID potentially have shown us a lot of new pathways and a lot of new things. So this is, remains to be seen, I think, in that particular question as well.
There's probably a related question as well that came up about familial HCM and what factors could cause that gene to express itself. Again, Helen, maybe that's something you can start off with.
Can Helen please defer to Professor Elliott?
That's a pass, that's fine.
So, okay, the easiest answer is we don't know. I think that's probably the bottom line. But I think, as I said in my talk, there are clearly gender effects. So, if you look at mutation carriers who are not expressing the disease, then if you're male, you're much more likely to develop an overt phenotype than if you're female. And there's gender differences. We see that across all the cardiomyopathies. In general, men are more severely affected than women, or at least affected earlier. Although in ARVC, it's flipped the other way. And I was looking at some data actually in between the talks and this session, and if you look at the electronic health records in the UK, there's been a 250% increase in the number of diagnoses of ARVC, and that's overwhelmingly in women. And one could explore reasons why that should be. Maybe it's completely non-medical factors, whether it's the way in which women present or not investigated, whether their symptoms are taken seriously. There's a whole pile of things it could be. So gender is one thing. Ethnicity may be another issue. So there may be variations in the presentation. And then what we always say is that it's what we call comorbidities. It's whether you've got obesity, hypertension, and so on. And there is some interaction, probably, between those common factors. But what I always say is a get-out clause for this is that, you're looking at a variant in a single gene, but you've got another 24,000 genes in there. And way in which diseases present. This is not, Helen, please jump in, but this is not particularly unusual that you see variation in the expression of a gene even within the same family. So there's a lot of other genetic factors which will determine whether a gene expresses itself.
Okay, thank you. I'm going to go and move on. We do, I think, as a society, we've got a lot more focused on measuring different metrics in our life, and I've had quite a few questions coming in about ejection fraction and how worried someone should be if it goes down, or what does that, how closely it should be followed. Jerry, maybe you can start us off on that one, if that's okay.
Yeah, no, of course. Thanks, Joel. So just for everyone, ejection fraction is a measure of how strong the heart is, and it's percent of blood ejected in one beat. And normal is about 60%, not 100%. So normal is about 60. And ejection fraction is important because we use it as the threshold for some of the things we do. So all the evidence for the drugs and dilated cardiomyopathy is only when your ejection fraction is below 40. Devices such as defibrillators, CRT pacemakers and defibrillators is when you're less than 35 after 3 or 6 months of good medical therapy. So it's a threshold for increasing treatment. But I think that's where it comes in. So you want to monitor it to see if you should be increasing up treatment. But there's a 5 or probably even 10% variation within the measurements if you're using echo. So I think this sort of, if you're well, you don't need 6 monthly echo. So if you're stable, you're on the right treatment, you've been stable for a while, actually it's only really a change in symptoms that should trigger an up-to-date echo. And again, just to stress, so there is 5-10% variability. So if it goes down a little bit, that may well be within the confines of the reproducibility of the test. And I guess the final thing is sometimes the echo isn't accurate because the pictures are difficult to get. And in that case, it's worth giving some contrast or doing an MRI, because just having an accurate assessment makes a big difference for when you change the treatment. But routine monitoring of ejection fraction, if you're stable, really isn't necessary.
Anyone want to sort of add on to that at all? Okay, I'm going to move to maybe our sort of final question. It's quite really good to hear from all of you on this one. So we've had lots of people asking, really, what's the best thing that they could do with someone with cardiomyopathy to help ensure that they get the best possible treatment. So it'll be interesting to see all your views really about, I suppose, what's your ideal patient, or what do you think a patient should be doing for themselves? Juan, should we start with sort of younger people? What do you think?
That's quite a difficult question. So I guess it's really important for patients and for their relatives actually to be sort of well educated in terms of their condition, because actually nobody knows themselves, and I always say this to parents, nobody knows your child better than you do. So actually we can ask questions about symptoms, we can measure things like ejection fraction on the echo, but ultimately what we're really interested in is how the cardiomyopathy is affecting that particular patient and that family. So actually having that, being able to have that sort of level of conversation, it's not just about the medical aspects, but it's about everything else, is really important. So sort of really, well-educated patients are able to educate us as sort of health professionals as well, about the conditions, but also about them and how the condition is affecting them. I think Perry said earlier that one of the major things that we always have to, that we should be focusing on is quality of life. So not just improving survival, but actually quality of life. And actually the best way that we can do that is by understanding how the condition affects the child and the family more broadly when we see you in clinic.
Interesting. Robert, is there anything you would want to add?
So, I mean, Takotsubo is perhaps slightly different from the others in some senses, in that you shouldn't necessarily be defined by it, and the triggers for it are so varied across the range. So, I guess what I would say is I think it can be helpful in terms of having something a little bit rarer to have this label to enable some discussion and education of other healthcare professionals, but it shouldn't necessarily define an individual's sort of life course and how they continue to live their life in the future. It shouldn't necessarily change anything from that point of view.
Okay, thank you. Anyone else want any sort of tips, advice that they would want to add?
Yeah, can I come in, John? I think this is a really important part of the whole relationship. So, patient-doctor should be an equal relationship, and I think that's incredibly important. And actually, the more involved the patient, the better their outcomes. I really think that's true. And there's a few simple things. Have your last clinic letter on your phone. Have a complete list of medication with the name, the doses, how often you take it. And I think for those on medicine, spend a bit of time every visit, go through your medicines. There's thousands of people on medicines they don't need to be on historically. We're great at starting medicines, we're rubbish at stopping them. So go there, be honest about your symptoms, your quality of life, go through your list of medicines, understand your diagnosis, use resources like the charity. But the more active role you play, the better your outcomes will be. So I think it's incredibly important, and we should keep stressing that. We really should.
Well, thank you for that. I think we've run out of time, but I do need to just sort of, first of all, thank you all for all our clinicians for your time on this panel and throughout the day, and really over the last 30 years, some of you for helping us as a charity. And just to reiterate, we literally had about 200 plus questions to go through, so we didn't have much chance. But we have, the helpline is up and running again on Monday, so do feel free to get in touch with our nurses on there over the week and make sure that we can answer your specific questions. So I'll leave it there. Thank you very much, everyone.